and we are going to start the post-lunch session. Our chairperson will be of this session is our beloved Dr. P.C. Rai and Dr. P.N. Singh. I request Dr. P.N. Singh, sir, to please come on stage and chair the session. Sir, we had a morning talk of 6 speakers. In the morning we had an insulin shot, then we had a shot of malaria vaccine. We had a talk on liver transplant. We corrected our vertigo and seizures, our pain, back pain and everything. And now we are with interventional cardiologist with 15 years experience, cardiologist at Yashodhara Hospital, Sholapur, and associate professor at Government Hospital, Sholapur, Dr. Amjad Sayyad. He is also running a center, Noble Heart Care Center. I request Dr. Amjad to please come and deliver his speech. A big hand, please.
Very good afternoon. First of all, I should thank the organizers and delegates to give me this opportunity to talk in front of you. Today's topic of discussion is one of the deadly diseases upcoming and increasing in magnitude in India, and a different kind of spectrum seen as compared to the Western countries. It's coronary artery disease. So we are dealing, today's talk is on acute coronary syndrome, which is the clinical spectrum of acute coronary syndrome comprises of unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. This is characterized by common pathophysiology of disrupted atherosclerotic plaque. Mobile. Just take this. So basically, acute coronary syndrome, it's all about first the diagnosis, the silent features of the differentiating from the other causes of chest pain, and then clinical scenario, and the diagnostic test and the management. So to begin with, how the pain is exactly. The onset of pain. The most important ischemic cardiac pain, the onset is usually, there's a waxing and waning phenomenon and there's a warm-up phenomenon. It doesn't start abruptly, it starts gradually. The provocation or palliation. Usually cardiac pain has some provocating factors like if you exert emotionally or physically, it increases and it gets elevated by taking rest or sublingual nitrates. The quality of pain. The pain is usually described by patients as a squeezing pain or something burning in the chest or some tightness in the chest, and it is more of a discomfort rather than a pain, unlike pleuritic and other pains. And radiation. The pain usually radiates from the retrosternal to the shoulders, jaw. It hardly ever radiates above the jaw and below umbilicus. Site of pain also is very important. The pain is usually substernal and it is usually diffuse. It is not very localized. And timing of pain. The duration. Somebody says there is a pain for last 3-4 days continuous. It's unlikely anginal because it comes in episodes. It lasts for a particular time. So we're basically talking about unstable angina, that pain at rest. This is a classification given by Braunwald in 1989. It's all a clinical classification, but it's very simple to understand. Any new onset chest pain or accelerated chest pain, which was previously present, or very severe chest pain, is called a class 1. Class 2 is at rest and subacute. There is no episode in last 48 hours. Before 48 hours, there was a pain. Class 3 is at rest and acute, but within last 48 hours. And A, B, C. A is secondary to some other supply-demand mismatch, like there is anemia, there is decreased blood supply due to other factors, metabolic issues. It is secondary, but more common is the primary. It's a coronary artery disease, obstructive disease, or post-MI, after myocardial infarction. And there is small a, b, and c. is on minimal treatment. This patient, some patients on aspirin or something, if they produce unstable angina, it is say class A, small a, and some on standard treatment. B and C is maximum medical treatment. All anti-anginals, beta blockers, and all drugs are on, but still they get angina. So the worst scenario is class 3C and small c. This is the classification given by Braunwald. Of course, now the classification based on troponins and myoglobins are coming up, but this is the old and gold standard for clinical diagnosis of unstable angina. And what about myocardial infarction? Mind you, the difference between myocardial infarction, unstable angina, and ST elevation MI and non-ST elevation MI. So the only difference is in unstable angina, the troponins or cardiac enzymes will be negative. In non-ST elevation MI, there is no ST elevation in the ECG, but there are some ECG changes, and the cardiac enzymes like troponins or myoglobins or other CPKMB will be positive. And of course, ST elevation MI is frank ST elevation seen in ECG. That is called ST elevation MI, and which is the most dangerous situation. So the prognostic wise, unstable angina, then non-ST elevation MI and ST elevation MI. But exactly, it's not all the time, but it depends on different clinical factors. One of the classification which was given by American College of Cardiology and American Heart Association and Joint Task Force is classification of MI, spontaneous occlusion of coronary arteries, that is coronary artery disease, that is a classic MI. Then secondary to ischemia imbalance, as I told you, if there is a mismatch because of coronary embolization, other than coronary artery disease, occlusion of coronaries, or supply-demand mismatch. Or third type is sudden death. You must have heard somebody suddenly died, there was some sweating and chest discomfort. This is called type 3 MI, there is no biomarker, there is no ECG available. Then type 4, there are two types, post-angioplasty, without stent problem, because of side branch occlusion, we are doing angioplasty, there's some side branches get occluded, so they produce chest pain and cardiac enzymes positive. So it is called type 4A. Type 4B is stent thrombosis. We do angioplasty, you put a stent, it gets thrombosed and there is a MI. So it's a post-stent angioplasty. And type 5 is post-bypass surgery. It's many factors are responsible for post-bypass surgery, myocardial infarction. We just looked at what are the features of unstable angina. These are the features of stable angina. So there are three factors: substernal chest discomfort, onset with exertion or emotional stress, and relief with rest or nitroglycerin. If out of these three, if there are two present, then still it is called atypical angina, but angina. And non-cardiac chest pain is if either of only three is present, one of the three is present. So classically, you see a lot of patients moving around with you, around you and saying that whenever slightly exert, get discomfort, I need to stop. That is a very classic stable angina. If it has recently onset within one month or so, still it could be an unstable angina. To know what is angina exactly, first we should be able to differentiate what are the chest pains which are not classic of an angina. These tips are given by American College of Cardiology in 2009. The pleuratic pain, it's a sharp knife-like pain, it increases and decreases with respiration. The primary or sole location in the mid or lower abdomen, unlikely to be anginal. Discomfort localized with a single finger. Somebody touches the chest and says, this is the area only I get pain. So it is unlikely it is anginal because anginal pain is slightly diffused. Then discomfort reduced by moment or palpation. If there is a tenderness on the chest, very unlikely, almost not possible that it is angina. It is something different. Then constant pain lasting for days or hours, also it is not anginal. Then fleeting pain lasting for few seconds, just somebody says 1 or 2 seconds I get pain. If you see the time wise, angina usually lasts more than 10 minutes. If it is around 20 to 30 minutes, it's unstable angina. If it lasts for hour or 2 hours, it is usually myocardial infarction, but not always. And pain radiating to areas where it is not described, like lower extremities and above mandible, unlikely to be an anginal pain. So there is a diagnosis of ischemia for pain. The chest pain patient comes to you, what should be in your mind other than coronary artery disease? And which is more deadly situations like aortic dissection, myocarditis, pericarditis, the cervical disc diseases, costochondritis, which is very oftenly seen, then fibrositis and herpes zoster, then pulmonary problems like, even though not cardiac, but then it is again, 1 of the cardiac emergencies, that is pulmonary embolism and tension pneumothorax, There are some psychiatric disorders, somatoform disorders, and most important, which mimic sometime angina, and even it is relieved by sublingual nitroglycerin, is esophageal pains. Sometimes you get esophageal spasms, gastroesophageal junction spasm, which is classically retrosternal, burning-like thing, and it comes in episode, and even it responds to nitroglycerin. So it is sometimes difficult to differentiate, but then the other test may reveal what is the problem. These are the different duration of pain, gastroesophageal reflux pain and spasm pain, biliary pain. It is usually in hours and all. But then anginal pains are usually in minutes or maximum 1 or 2 hours. It usually subsides by treatment or sometimes without treatment as well. So what are the features which are very classic for angina? There were, this is a statistical analysis of many studies which were reported on the questionnaires of discomfort and other associated symptoms of coronary artery disease. So if you see this, the most common thing is if the both shoulders are tightly, chest pain, both shoulders together at one point of time, it is very specific for anginal pain. Then again, left arm, the chest pain, the other thing is like nausea, vomiting, sometimes sweating. Sudden profuse sweating is one of the very classic features of anginal chest pain or acute coronary syndrome, which is usually seen only in cases of acute coronary syndrome and sometime in stroke. Of course, if it is organic, some other issues are there. Third heart sound in auscultation. Usually during myocardial ischemia, there is a production of third heart sound which is audible on auscultation. If you see the audibility of third heart sound, angina is more likely. Hypo or usually hypertension, both, or sometimes heart failure leading to pulmonary crackles. These are the features. So what we do, once we see the patients of chest pain, and to differentiate, of course, if our clinical skills are not polished or we are not non-cardiologist, non-physician, because maybe there are people amongst you who are looking at a general OPD. So what to do? You have to keep them under observation for some hours and do serial ECGs rather than one ECG, because it has been proved beyond doubt that even acute myocardial infarction patients have normal ECG till end in 4 to 5% of the cases. So normal ECG doesn't rule out acute coronary syndrome. So such patients should undergo serial ECG for at least 12 hours, every 2 hours you say, and you see the dynamic changes. Sometimes there is only mild ST depression which disappears. Sometimes there was normal ECG, there will be mild ST depression again which disappears on third ECG. So this is called dynamic changes or progressive changes. So there are no changes initially, there is mild ST depression, it goes on increasing and then becomes a T-inverted in other ECGs progressively. It's called progressive ECG changes. On ST depression and elevation, you know, these are the signs of ischemia. Then Q waves, there are a lot of things about Q waves in the past, but nowadays it has not a clinical significance unless the particular amount of duration of Q waves is seen on ECG and it doesn't correlate with the pathological infarct size or any area of infarct. New onset left bundle branch block in ECG, new onset right bundle branch block, or any new onset arrhythmias, either bradyarrhythmias or tachyarrhythmias. Along with of course, these all ECG changes, along with the clinical syndrome of chest discomfort or a scenario of some middle-aged male with many risk factors. If that is a scene, then of course, although all ECG changes should be clinically correlated rather than just an ECG diagnosis of acute coronary syndrome. So, what exactly we discussed the syndromes is no ST segment elevation, it is an unstable angina or a non-ST elevation MI, or before it was called non-Q MI. And the most important steps are history and physical examination, ECG, and we proceed for the treatment part of it. So what is the role of echocardiography in acute coronary syndrome? Because day in, day out, I told you there may not be a ECG changes, and then the most important test is echocardiography, because easily available, non-invasive, and relatively cheap test. What do you see in echocardiography in acute coronary syndrome or a patient with chest pain? First thing to see is regional wall motion abnormality in left ventricle, because any territory that is coronary involvement is there. Suppose there is a right coronary artery involvement, there is inferior wall hypokinesia. If there is a left anterior descending artery involved, there will be anterior wall hypokinesia. So there are different kinds of regional wall motion abnormalities in acute coronary syndrome. or there may be sometimes global hypokinesia in a patient who has a triple vessel disease or a patient who have a left main coronary artery disease. Then chamber size and function is very important in a patient with acute chest pain. I'll say one by one. If the left side chamber is suddenly dilated, it again indicates there is a ischemia. If the right heart is suddenly dilated, which was not there before, or even you see, so what may be the cause? The right heart dilatation happens in acute pulmonary embolism because the embolus block the pulmonary artery and there is acute dilatation of the right heart. Then again, mitral regurgitation. This happens in acute coronary syndrome or acute myocardial infarction because there is a papillary muscle dysfunction. The blood supply to the papillary muscle is hampered, so there is improper coaptation of the mitral leaflets leading to regurgitation of blood from the left ventricle to the left atrium. Then that is called acute mitral regurgitation. Then tricuspid regurgitation, again pulmonary embolism because of dilatation of the right ventricle, there will be a regurgitation of the tricuspid valve. Then acute aortic regurgitation. This is seen in chest pain patients during aortic dissection because most of the ascending aorta there is a start of dissection and there will be improper coaptation of the aortic valves. Then sometime you may see the aortic flap in the ascending arch or descending aorta in a different views, suprasternal view or epigastric view or parasternal views in echocardiography. Then pericardial effusion can be seen, which may be the cause of chest pain, that is pericarditis or maybe post-MI pericarditis. Then ventricular septal defect. As a complication of acute coronary syndrome or as a complication of acute MI, there will be a ventricular septal defect which could be picked up on echocardiography. So what other things? Echo, ECG and biomarkers. There are some limitations for the biomarker. Again, you need to wait for some time. I'll tell you just a story of recently, a few days back, I had a patient, in fact, he's a worker in our hospital. He was a very young guy without risk factor. He came, he said, sir, there is a lot of sweating after my exercise and I felt some discomfort in the chest. We did the ECG, normal. Some resident sent immediately the biomarkers as well, troponin, but before I reached there, it was normal. Then what to do? But the pain was very classic. I called the echo, then echo, again it was normal, but pain was really very classic and he was sweating like anything. So benefit of doubt, whatever thing, we did angiography. There was a ostial critical left anterior descending artery disease, 99%, and we did an angioplasty. So before development of ECG changes, before cardiac enzymes were positive, before there was a defect in the echo, we could salvage him, and so there was not a single loss of ejection fraction or nothing. This was almost 3 months back. Now he's doing very well. So this is an example when your clinical suspicion and your symptomatology study should be very high at suspicion and you should follow it properly with the investigation rather than basing only on investigation. Biomarkers, again, serial biomarkers are important. It should be done serially. You should see the rising titer in the biomarkers like troponins and CPKMB or myoglobin. And timing of the biomarkers is also important. There is some graph I'll show you. For example, if you want to do a troponin, usually it comes positive after 6 to 8 hours. And it is recommended, though it is sensitive and specific, it is not positive in first setting after 6 to 8 hours. It should be repeated after 12 hours. So serial and timing, both is important. Then sensitivity or specificity of biomarkers is important. The most sensitive and the most specific biomarkers is troponin now, as of now. And quantitative tests should be done so that the progressive increase in the biomarker levels can indicate there is a myocardial injury or necrosis. This is the diagram which shows the myoglobin is supposed to be first appear in the blood within 3 to 4 hours after the acute event. But it is not routinely available. What we do is troponin I or troponin T, which is positive within 6 to 8 hours after the myocardial infarction. And it remained positive for 10 to 14 days. So most important is a pathophysiology. Understanding pathophysiology of acute coronary syndrome is very important because you can see this, the aging process itself leads to the formation of plaque in the subintimal area of the coronaries. So that consists of smooth muscle, then your lipid-laden macrophages and inflammatory cells, and a lot of cholesterol material which is laden in the macrophages of. So what happened when they start accumulating the cholesterol in the macrophages of the subintimal? There is a formation of plaque which grows, and there are two types of remodeling. One is expansive remodeling, and one is constructive. So both are dangerous. you may think that there is a constructive remodeling is dangerous, but sometimes even expansive remodeling, there is a plaque rupture and formation of clot and occlusion of coronary artery. So there are two terminologies regarding the coronary subintimal plaque. That is culprit plaque, that is a retrospective. That means the plaque is ruptured and lead to MI, that is a culprit plaque. And one plaque is called vulnerable plaque, which is a prospective terminology. So our focus should be vulnerable plaque. What we do, we treat as an intervention cardiologist is culprit plaque. What I do, somebody suffered a myocardial infarction, I do angiogram, I see there is a stenosis, that was a culprit plaque for that heart attack, I fixed it with a stent. But I don't look at the vulnerable plaque, which is again prone to lead to myocardial infarction next time, because it erodes, it leads to formation of clot. So that is where importance of medical treatment and preventive management of coronary artery disease. Because as an intervention, probably we do intervene late in the scene. Same thing, I think you should skip, there are a lot of slides. Yeah, so what is vulnerable plaque? There is a criteria for vulnerable plaque. I'll just show you. Yeah, the next other slide. So rather than only vulnerable plaque, somebody coined the term, there's vulnerable patient, because plaque is not the only thing which is responsible for everything. So there was a study in which they studied the severity of coronary stenosis before myocardial infarction. So they say the maximum number of plaques are less than 50%. So what we treat as a cardiologist or cardiothoracic surgeon, we treat plaque more than 70% of the stenosis. We do bypass or angioplasty more than 70, but what about less than 50? Because they're more in number and they're prone for myocardial infarction. So this is taken from the study from the European journal. The number of ruptured things was 70% and stenotic were only 20%. It is a retrospective study, pathological study after myocardial infarction. So most culprit things are 50% or less than 50% stenosis is more culprit lesions. So what are the features? The plaque instability because of thin cap, inflammation in the plaque, shear stress of hypertension and other oxidative stress, large lipid core, lot of accumulation of lipids in the plaque, and endothelial dysfunction because of risk factors of diabetes, hypertension, smoking, and vascular spasm and formation of thrombus. Once the plaque ruptures, there is a formation of thrombus and lead to occlusion of coronary artery. So it all depends on percentage of stenosis, frequency or number of plaque, and risk of complication per plaque. So it is a complex phenomenon. We cannot say that only if there is a 90% lesion they will have MI, but there is a complex phenomenon. Like these are the different types of plaques. The prone inflamed plaque. The vulnerable plaque, you can see this exposed proteoglands prone to thrombosis. Again, there is a formation of thrombus that can occlude the whole lumen of coronary, leading to myocardial infarction. Hemorrhages in the plaque. You can see this, there is a lot of smooth muscle cell. This looks like a stable plaque, but there is a severe stenosis. So what are the major criteria? Active inflammation, thin cap, endothelial degeneration and superficial platelet aggregation, fissure wounded plaque, and more than 90%. If these are the criteria, there is a vulnerable plaque. And there are some minor criteria. I won't go into the details. So factor contributing to plaque vulnerability is low smooth muscle cell. Plaque contains smooth muscle cell. If the muscle cells are less, it is unstable plaque. It can break and lead to thrombus formation, large lipid core, thin cap, and high macrophage content. So what we can target therapy-wise as of now is statins, high dose of statin which target on high macrophage content, which can be reduced. This is the gadget which you study the plaques in the coronaries. I think we'll not go into the details. So beyond the vulnerable plaque, there is a concept called vulnerable patient, vulnerable blood, and vulnerable myocardium, because that's all important. Because vulnerable patient is a patient with all risk factors of hypertension, diabetes, smoking, hyperlipidemia, and vulnerable blood is a blood in which there is all factors which are responsible for like unseen factors like protein C deficiency, unknown risk factors for coronary artery disease, and vulnerable myocardium because the unstable myocardium which are prone for arrhythmias can lead to acute MI, lead to sudden cardiac death. Yeah. So coming to the ST elevation myocardial infarction, what are the management guidelines? So based on different trials and studies, so we have straight away, if there is a ST elevation myocardial infarction, the treatment of choice is either thrombolysis or go for angioplasty. But in case of non-ST elevation myocardial infarction and unstable angina, it depends on the risk stratification of the situation, whether to go for initial medical management followed by angiography, angioplasty, or directly going for angiography and angioplasty. So this is a TIMI risk score in patients with NSTMI or unstable angina. If the risk score is high, like age, the patients already on aspirin or ST elevation or depression is more. So if the risk score is high, these patients should go for angioplasty directly rather than keeping them on medical management for some time. So that risk should be calculated. Nowadays the calculators are available. The thing say, like, if the risk is low, chest pain center, patient can be observed. If the risk is intermediate, invasive approach or conservative, both can be. If the risk is very high, like in ST elevation MI or non-ST elevation MI unstable angina with heart failure or other risk factor like hypotension and all things. So what are the patient? Immediate angiography and revascularization. Hemodynamic instability and cardiogenic shock, they should be immediately wheeled to cath lab to see the coronary anatomy and followed by this strategy. Left ventricular dysfunction or heart failure, yes, they should go for early invasive therapy. Recurrent or persistent rest angina despite intensive therapy, they should early go for early management of invasive management. And worsening mitral regurgitation and new septal defects, sustained ventricular arrhythmia. These are the patients. Once you see in the ICU, you should not wait for referring to the center where the cath lab is available. What are the goals of revascularization? Decrease amount of myocardial necrosis, preserve left ventricular function, prevent major adverse cardiac events, and treat life-threatening complications of myocardial infarction. So these are the goals to save the muscle, in fact, to make the early revascularization. So how do you do it? Opening the blocked artery by reperfusion strategies. Most commonly done is pharmacological, that is thrombolysis. The mechanical, that is primary angioplasty. Or nowadays, a new concept has arrived, is a pharmaco-invasive approach, because the availability of cath lab or invasive therapy is not there everywhere. So there is a strategy of pharmaco-invasive. Yeah. Time is a muscle. This is taken from the circulation in 1977. You see the time passes, the amount of necrosis goes on increasing. So the early you intervene, early you open the blocked artery, the amount of myocardium you save is more and the life saved is more. Same thing, the time is a muscle. So if you do intervene early, the infarct size is decreased. So there is some concept called door to balloon time or door to needle time. What is door to balloon time? If I am going to do angioplasty for a patient with acute MI, the moment he arrived in my hospital till I opened a balloon in the coronary of that patient. So from the casualty to the cath lab, and in the cath lab, when I insert a balloon and open in the coronary, that is door to balloon time. If this is usually calculated or estimated. Suppose I think if the patient is with me in my casualty, if I think I will not be able to do angioplasty within 90 minutes, then I should change my decision and go for thrombolysis, because it is estimated that if the door to balloon time is more than 90 minutes, mortality increases. So you should not waste time for thrombolysis. At least you can give thrombolysis. Because there is a lot of technical issues, the availability of cath lab, cardiologists, finances, somebody taking decision for the patient, all things. So if you estimate the time is more, you just go ahead and go for thrombolysis. So what are the preferred reperfusion strategies? That is thrombolysis. If it is less than 3 hours of chest pain, definitely thrombolysis is equal. Sometime you say, but then gold standard is again angioplasty. If the PCI is not available, you can go for thrombolysis. If the door to balloon time is more than 90 minutes, then thrombolysis. Door to balloon time is complicated, I should not discuss it. Door to needle time is arrival of the patient to the thrombolysis. If it is less than 30 minutes, then only go for fibrinolysis. If you think that even fibrinolytic agent is not available or something is that you can delay it, then you wait for some time, hypernize the patient and send for angioplasty. All the cases, angioplasty is preferred. There is not a single case where angioplasty is not preferred, but the time is important. This is the TIMI-3 score and associated, So different kind of thrombolytic agents we are using: streptokinase, alteplase, reteplase, and tenecteplase. So streptokinase is gold standard, but then was before. Now alteplase, retiplase, these are fibrin-specific agents. So their patency rate after the opening of the capacity to open the artery, and 90 minutes patency rate is around 75%, you can see. But the streptokinase is less. Again, it is antigenic and all, though the cost is the issue, but then definitely tenecteplase is a gold standard as of today, and can be easily given in a single shot, unlike streptokinase, which runs for hours and leads to some complications. Tenecteplase is just 4 milligram or 5 milligram injection, single shot can be given, but the cost is the issue. So what are the limitations of thrombolysis? Increased risk of hemorrhagic stroke. Despite therapeutic advances, thrombolytic 50% reached TIMI3 flow after 90 minutes. Efficacy. If you compare thrombolytic agent with angioplasty, mechanically you go and open the artery and do angioplasty. In 99% of the patient, you open the artery, really. But then thrombolytic agent, maximum 50%. More than 50% is not possible with thrombolytic agent. Lack of reliable non-invasive method for assessing patency of infarct-related artery. If I give a thrombolytic agent, olden days it was said if the T inversion has come, ST elevation has come down, means artery is open. It is not the case. The angiographic studies doesn't correlate. So there is no test to confirm. Then there is a primary failure. Then there is a threatened reocclusion after thrombolysis. These are the limitations for thrombolysis. So angioplasty is really better in case of acute coronary syndrome or ST elevation MI. There is some absolute contraindication, and need not go into detail. History of intracranial hemorrhage, old cerebrovascular accidents and malformations or aortic dissection. These are absolute contraindications with thrombolytic agents. There are some relative contraindications like pregnancy or severe hypertension or dementia or stroke of more than 6 months. Next. So pharmacological versus mechanical reperfusion, which is better? There are so many trials performed, and definitely all came to the conclusion that mechanical reperfusion in the form of angioplasty, that is called primary angioplasty, is definitely better. There were some few trials in which they studied whether it is better to give some half thrombolytic agent and send the patient to the center where angioplasty is possible. That is called facilitated angioplasty, and that also worked better. And this meta-analysis showed that primary angioplasty was associated with significant reduction in short-term mortality of 34% in randomized controlled trial, and again long-term mortality also was reduced. But in case of the observational study, it was not proved. This is the way how we go about the angiography. Now we do most of the 90% of the time radial. This is a depicted femoral way. Go the balloon and the stent on the balloon, and once the balloon is inflated, the stent remains and the balloon is pulled out, and so the scaffold hold the coronary so that there is no re-occlusion. This is an example of primary angioplasty where you can see the A diagram. There is cutoff of coronary, left anterior, wire was crossed, the thrombus suction was done, and there is a result seen in C, there is some flow. But after the stent, you can see the D, there is a patency of the coronary artery was maintained. So what are the recent advances in angioplasty or angiography area? This thing, there are a lot of advances. The list is huge, but then few things which are approved and were done in the practice, like now radial approach for last 1 decade almost. We are doing radial primary angiography and angioplasty, a lot of comfort for the patient. They can walk in and walk out without any issues. Then drug-eluting stent, different kinds of drug are available and different platforms. So the 3rd or 4th generation stents now we are using. The bioabsorbable stent. The issue was whether the stent remained in the body. It is after all a metal. So there is a formation of thrombus on that metal because there is no proper neo-intimal proliferation on the metal because of the drug-eluting stent. So what they did is a bioabsorbable scaffold was formed. It get absorbed within 3 months. So there is no metal in the body. The initial part of the initial work of the stent is to keep the patent artery patent. It should not reocclude. And once its job is done, it disappears from the body. It gets absorbed. That is called bioabsorbable stent. But there are some limitations. Not every patient can undergo bioabsorbable stents, and cost is another issue. Thrombus suction. In acute coronary syndrome, when we do angioplasty, what about the thrombus which was there? We try to push it forward. It goes to the distal vasculature. Again, it blocks the distal arteries. So again, it's harmful. So try to suck the thrombus. There are different mechanisms or different gadgets we are using now to suck the thrombus. Then drug-eluting balloon. There are a few situations when you cannot deliver a stent. then what we do, a balloon is taken which is eluted with the drug and just inflate there, so that the drug acts as a antimetallurgic and there is a formation of, there is no restenosis or neointimal proliferation in the intima. So that drug is delivered by the balloon and balloon is taken out. That is called drug-eluting balloons. This is usually done in restenosis after angioplasty. Then distal protection device to prevent the distal embolization of the thrombus during coronary this thing. Then IVUS, OCT, FFR guided angioplasty. IVUS is intravascular ultrasound. What ultrasound we do for heart or abdomen, this is also done for coronaries. The wire, the coronary wire is a probe, and it shows the, around the probe, it shows the whole intima, media, and all the 3 layers of the vessel and what it contains. That is called intravascular ultrasound. And based on that is optical coherence tomography and fractional flow reserve. These are the tests with which we can do angioplasty, guided angioplasty, so that our stent placement and our angioplasty is very optimal based on all these gadgets. Then rotablation is done for calcium. Calcium is one of the big hurdle when you put a stent in the coronary. So how to break the calcium? There are now burrs available. It goes into the coronary, it rotates and just rub the whole calcium and disappears, and then you deliver a stent. That is called rotablation. These are the recent things which is coming up in the angioplasty. I'll just show a few slides about the thrombus suction. With this catheter, this is the catheter which sucks the thrombus. See, this is a thrombus just taken out from the coronary. So this is very hard. This was taken out by myself in 2008. Of course, there are a lot of things I've taken out, but this is the only diagram I have. So this is 2008 in Hyderabad. So when I touch it, it is not able to break it. So how are you able to thrombolize it with the drug? You're not able to break it with your hand. So I practically took it out from the coronary with the thrombus suction catheter. So that is the only, I think, treatment for the patients with such kind of a hard thrombus. So thrombolytic agent won't work. So thrombus suction catheter, there was a lot of controversy whether it's really helpful, because during the process of sucking thrombus, you may dislodge again a lot of thrombus. So whether it's really helpful. So ultimately, the initial vampire trial, then topaz trial, and then meta-analysis of all trials, ultimate suggestion is it really helped. So it definitely decreased the long-term, short-term and long-term mortality. So thrombus suction is routinely done in acute MI cases during angioplasty nowadays. As I told you, facilitated PCI. So what is a pharmaco-invasive approach? I was telling you pharmaco-invasive approach is where suppose now here you get a patient of acute MI and you want to shift. Of course, Sholapur is nearby, but suppose some places 80 to 90 kilometers away from Sholapur, where the cath lab is only in Sholapur. So what they do? They should thrombolize the patient immediately, and during after thrombolysis, they should immediately shift the patient. In previously, what was the strategy? Once you thrombolize the patient, just watch the patient at least 2 to 3 days, 4 days in the ICU, then shift outside the ICU. Then after 10 to 15 days, take the patient on treadmill, ask him to walk, whether he is able to walk. And then there is a chest pain or ECG changes, then only send for angiography. The whole scenario changed after Gracia trial and Gracia registry in 2008. It is said that every thrombolized patient should undergo angiography within 5 to 6 hours after thrombolysis, because it is not sufficient, only thrombolysis is not sufficient. So you need not be base your decision on ischemia guided strategy or demonstrating ischemia or treadmill, demonstrating ischemia on other angina strategy, whether pain is not relieved, so I am sending patient for angiography. That is not the strategy now, as of now. The strategy is every patient should undergo angiography after acute MI or even after thrombolysis, even if he is not symptomatic. So that is the timing. Again, the main important part of the talk is why stents are not enough. Because stents treat lesions that are selected on luminal stenosis. As I told you, the responsible lesions are less than 50%. We don't stent them. We don't do bypass for that lesions. So stents are not enough. The plaque events are determined more by plaque biology rather than by stenosis. So what do you do? So coronary disease is diffuse and progressive. You cannot stent all the areas of coronary. You stent the maximum stenotic area, you leave other plaques like that. Then PCI at discrete site does not alter the disease burden or progression of the disease. So what do you do? The answer to this question is you have to go for medical management and preventing the plaque rupture, that is high dose statins. So maintaining the intact plaque is vital, and worst looking lesions are least likely to rupture, less severely obstructive plaque are more numerous. So you need to treat them in form of medical management. Why statin? Statin directly alter the coronary artery disease natural history through lipid lowering and other direct cellular effects. Effects on mortality and morbidity in very large studies in primary and secondary prevention be proven beyond doubt, even with angioplasty. High dose, more potent, newer statin can achieve plaque regression as well. This is in the, like rosuvastatin, there are few trials which have shown that there is a regression of coronary plaque, which was not possible before. Even with the high dose of atorvastatin, it was not shown that plaque regresses. What they do is plaque stabilization. The amount of stenosis or amount of cholesterol content will not increase in the plaque, but with rosuvastatin it is proved, at least on imaging studies, that there is a plaque regression. So stenting symptomatic stenosis combined with high dose statin therapy is currently best coronary artery disease management strategy. So what are the levels to treat? Then you have to risk stratify your patients based on different risk calculation scoring systems. Like this is NCP score. There are other Framingham scores. So we see what is your desirable levels of LDL cholesterol. Optimal is less than 100. Then near normal is 100 to 130. Borderline high is around 160, and very high is more than 160 and 100. So these are the different levels of your cholesterol, HDL, LDL, and total cholesterol level, which should be treated. So what are the definition of very high risk in National Cholesterol Education Program guidelines? It is American guidelines. Multiple major risk factors plus established coronary artery disease. These are called very high risk patients. You need to reduce your LDL levels below 70 in such cases. Need a high dose of statin therapy. Severe or poorly controlled risk factors, especially smokers. Next. Multiple risk factors like metabolic syndrome and acute coronary syndrome. These are very high risk patients. You need to treat them with optimal doses of statins, especially atorvastatin or rosuvastatin. Yeah, so calculation of the risk score is very important in a patient who comes to your office without even, suppose it's an old MI, we are not talking about acute coronary syndrome now. A patient, you have to calculate the risk. If the risk is between below 10% or 10 years risk, or 10 to 20 and more than 20. More than 20 is a very high risk patient. So what all you have to do is therapeutic lifestyle changes plus medical therapy. So if the risk is more than 20, yes, definitely the target should be less than 70 LDL levels. And that can be only achieved with not only with medical management, but equally active therapeutic lifestyle changes. That is very important. This is in Indian population. This is one study from Indian. This thing, the total cholesterol should be less than 160. LDL should be less than 100 or 70 if the patient is suffering from coronary artery disease or diabetes. And non-LDL HDL target is less than 130 and 100 if there is a diabetes or coronary artery disease. So what usual mistake is done is during acute MI, third or fourth day blood test is taken and cholesterol is measured. So this is a diagram where you can see what are the dips and rise of LDL and triglyceride and HDL. So ideal time to measure your cholesterol level of a patient who suffered a myocardial infarction is within 24 hours of myocardial infarction or after 1 month of myocardial infarction. That gives the real cholesterol levels. So that is a So what about the specific about Indian population? We have involvement at younger age because of our genetic behavior of the Indian race. That is called you must have heard about the thrifty gene theory, because we are not used to this junk food and other lifestyle changes which is happening, westernization happening in our country. We are not used to all these things, so our genes are not acting appropriately, and our cholesterol level and our atherosclerosis process is increased. We have smaller coronary arteries which can not be stented properly, or bypass also is very difficult in small coronary arteries. Diffuse disease, most of the Indians have diffuse disease, multiple blocks in a single coronary, again difficult to treat interventionally, medically also. And multi-vessel disease, Indian suffers more multi-vessel blocks, not single block. And even Indian women are more prone for coronary artery disease than in Western women. It's all because of genetic this thing. So what you can do in your clinic as a general practitioner or a non-cardiologist or non-physician, what you can do is risk stratify a patient with a chest pain. First, try to find out clinically whether it's a real ischemic, cardiac ischemic pain or non-cardiac ischemic. Then you see the ECG, blood pressure, heart rate, respiratory rate. Try to convince the patient, counsel and relatives and patient that is a really problem where he should get admitted and seek a different team. Then communicate with cardiologist and team. Then what medication you can offer at the OPD level is loading doses of aspirin, clopidogrel, atorvastatin or sublingual sorbitate to relieve the pain, heparin and some antihypertensive if the pressures are high. This much you can do for all patients of acute coronary syndrome. Anybody can do this. All doctors, even non-cardiologist and non-physician. Thank you.
Hello. Thank you, Dr. Amjad, for a very nice presentation and on a very common topic and very important topic. This topic is probably discussed in every conference of ours, and most of our projects are located very far. Not even, you said just 30-40 minutes, it's almost 6 hours, 7 hours, 12 hours.
Yes.
We have got very senior physicians in the house today. Dr. Goyal is there. Have you got any question or anything to add on? Dr. Goyal, Dr. Mishra, Dr.
Any queries I'd like to really discuss? Yeah.
As far as rightly pointed out that majority of us are located at very awkward geographical locations. Our projects are very well remotely located. So in one way our patients are fortunate enough that the door to needle time is very less. It is lesser than in the big cities.
Yes, sir, yes.
Hardly we provide within 15 minutes to 20 minutes they reach, and in the majority of the cases our thrombolysis is successful.
Yes.
But PCI is out of question at our setup. So one thing, what is the criteria? What we use the criteria for thrombolysis, successful thrombolysis is the disappearance clinical, that is disappearance chest space, the settling of ST segment settlement, and another is the peaking of CPKMB. Yes. These are the criteria what we use for successful thrombolysis. Of course, may or may not be correct. And then we send the patient to for PCI. So what should be the minimal time? We feel that it is successful thrombolysis. That you have rightly pointed out that in unsuccessful or failed thrombolysis, patient should be sent to for PCI.
Sir, I'll share you some data with you. Successful thrombolysis, if you clinically say it is not foolproof because it is studied properly. Suppose 100 patients underwent thrombolysis, they did angiography after thrombolysis. And even though the ST elevation has come down and there is chest pain has subsided, patient has not gone into heart failure, there is no complaint of chest pain again, very stable patient. Again, the chances of having more than 70% lesion are more than 90%. Yeah. Only 10 to 20% patients really have less than 50% lesion. Of course, Tpc flow, that is good flow after even 90% stenosis, can be established with your thrombolytic agent. But then obstructive lesion is definitely there. So these all, like what we use a criteria for successful thrombolysis ECG wise is ST resolution after 60 minutes or 90 minutes. After thrombolysis, we take a ECG after 60 minutes and 90 minutes. And if the initial ST elevation was suppose 100 and now it is 50 or less than 50, it has come down more than 50%, I said it is a successful thrombolysis. But then this also studied by angiography correlation, it doesn't correlate at all. So what strategy should be followed? Because open artery hypothesis means once you artery is blocked and if you open it, you not only prevent the immediate mortality, you prevent long-term issues. Suppose your artery remain occluded and you say clinically patient is fine, so you don't do angiography and angioplasty. The long-term slowly there will be necrosis will increase, like ejection fraction will decrease, and patient goes into slowly in chronic heart failure. Then there will be scarring in the myocardium leading to arrhythmias in the future, ventricular tachycardia. So the importance is you have to open the artery. That is called open artery hypothesis. So you don't know, unless angiogram is done, you don't know what is inside. So the previous thought of successful thrombolysis is no longer taken. So it is said that with the streptokinase, after 4 to 6 hours you can send, and with tenecteplase within 7 hours you can take for routine angiography. Failed thrombolysis, which is obvious to you, like suppose you thrombolize, the ST elevation has not come down, patient is complaining of chest pain, there is hypotension, there is a heart failure, then of course this is called failed thrombolysis. You take the patient for rescue angioplasty. But so-called successful thrombolysis also should be taken for immediate angiography followed by, if required, angioplasty. That is the dictum, that is the guideline as of now.
Thank you. And second question is there any, with the limited resources, is there any way to find out the vulnerable plaques, to identify and the vulnerable plaques, how to diagnose?
Vulnerable plaque.
Vulnerable plaques.
So vulnerable plaque, the studies were done, is all actually just a research thing. Somebody who has already suffered coronary, like risk factor equivalent, somebody around 40, all risk factors, like maximum risk factors like smoking, hypertension, diabetes, they bound to have plaques. Or of course somebody's already suffered a myocardial infarction. As I told you, there are more less than 50% plaque than 90% plaque. So such patients are definitely having vulnerable plaque. CAD or equivalent patients or high risk patient for coronary artery disease. So they all have vulnerable plaque. If you really want to study the plaque morphology, as of now, there are no indication to just study the plaque in a normal person without any, like suppose you want to see, of course we have intravascular ultrasound now, we have non-invasive test also like CT coronary angiography which study the plaque morphology. So of course you can go for it, but there is no indication. Only patients with established coronary artery disease or a very high risk to develop coronary artery disease like coronary artery disease equivalent, like suppose a diabetes. So they need to be treated and they need to be checked their cholesterol, and the target should be less than 70 so that your plaque regression or at least plaque stabilization occurs. So your question original was how to see for the plaques. It is really not possible. You just see as of now there is no indication to do the angiography and intravascular ultrasound to see the plaque because there are numerous plaque. This is not indicated, invasive test. Yes.
Thank you.
After angioplasty, the initial 2009-8 guidelines were up to 12 months. Now it is said that up to 6 months it can be given, and then, the issue is a dual antiplatelet or single antiplatelet. Single antiplatelet should be given lifelong. But if there is an issue with the dual antiplatelet therapy, you can stop it after 6 months to 1 year. But then a lot of studies have shown that even stopping antiplatelet therapy after 1 year or 2 years led to stent thrombosis, especially in drug-eluting stent, because drug-eluting stent is a drug is the matter which prevent the proliferation of endothelium. So there is a raw area in the drug-eluting stent always. Once you stop antiplatelet, there is a chance of thrombus formation. As against bare metal stent, there is a neointimal proliferation and the intimal surface is not raw. So chances of thrombus formation is less. In such cases, in bare metal stents, probably 3 to 6 months you can stop one antiplatelet at least. But in drug-eluting stent, I would recommend a lifelong dual antiplatelet therapy.
Thank you, Dr. Sahab. We are short of time and getting delayed. May I request RED Sahab to come on stage and give moment to speakers.
Thank you, sir.